echo session. And the topic is an interesting one, which all of us must be keen to learn more about. We're going to be looking at pediatric ART treatment optimization. You may also prefer to say pediatric drug optimization. And we have a very experienced clinician to take us through the presentation today, and we'll have an interesting case that will be presented by Mrs. Siamena Lavwe from Kabwe Women, Children and Newborns Hospital. So my names are David Singini. I work for the Center for Infectious Diseases Research in Zambia, CIDAS, in a project called TB Loan. So at this point, allow me to quickly introduce the didactic presenter for the day. He will introduce himself as he starts his presentation, but allow me just to also acknowledge the presence of our panel of experts. We have Dr. Rachel Thomas. Dr. Thomas, maybe you could greet the network in a few seconds. We also have Dr. Chungu. Dr. Chungu, are you with us on the call? Dr. Charlie.
Yes, good afternoon, Dr. Singini. Good afternoon, network.
Afternoon. And then we'll also have we'll have Dr. Chimika Piri. Dr. Piri, are you with us?
Yes, Dr. Singini. Good afternoon, network. I'm around. Thank you.
Thank you so much. We're so delighted to have you. So without wasting much time, allow me to invite our didactic presenter for the day to quickly introduce himself, and we can dive straight into the session for today. Dr. Mwiya.
Yes, good afternoon, everybody, and good afternoon, network. So like the moderator has mentioned, my name is Dr. Mwiya. Sometimes people call me the man without a surname, but the other name is Mwiya as my surname. And I'm at the Pediatric Center of Excellence, where I've been for some time. So I'm a pediatrician, and that is me. Thank you. So to start the presentation, when I was given the topic of pediatric ART optimization, first of all, I scratched my head as to what to say. But what I will say basically is it's the same things you know, but we package it in such a way that we try to demonstrate the importance of the actions that we take. Oh, no, my slides are not moving. Oh, sorry. So the first thing in our objectives that we're going to define what our optimization is. And then the second one is that we're going to discuss actions taken to enhance pediatric HIV drug optimization, and then discuss the newly introduced ART. So these are the main objectives for this session. But before I do anything, I would like people to define, since our main word is optimization, what does optimization mean? So this is our first question. Moderator, how many minutes?
I'll just give it a minute or two. This one looks fairly easy. So the first question, the first question is, what does optimization mean? Choose correct answers. So option A is to make something function at its best. B, to make something function most effective. C, use something to its best advantage. D, the action of making the best or most effective use of a situation or resource. And E, all of the above. So I invite the network to choose their best answer. We have about 54 connections on the call today, and so far only 5 have participated. So please choose your best answer, and I'll be displaying the results in the next few seconds.
This is probably, okay, as any
Okay, so we have an interesting voting pattern already. I think all the options have someone who has responded. Though I must acknowledge that we do not have option E on the launched poll. Apologize for that. We only have A up to D. But so far we have a number of people who have polled, and it's inclined towards one of the 4 options. I'll be displaying that answer soon. So just 10 seconds requesting that you participate in the poll so that we give Dr. Mwiya an idea of the knowledge gap that he needs to fill in by the end of the session. So I will end the poll and quickly share the results for you, Dr. Mwiya, to see, and also how the network polled. So we can see that 69% of the network thought D was the correct answer, which is the action of making the best or the most effective use of a situation or a resource. Again, apologies. Option E was not included on the poll for those that would have wanted to pick option E, but we can learn something from this. Dr. Mwiya, over to you.
Okay. Okay. My slides are failing to move. Okay. Hi. Just 1 minute. Looks like. Okay. So AR2 optimization. Sorry about the mix-up. So just to say that AR2 optimization. So optimization means to make something function at its best. It also means to make something function most effective, and also means to use something to its best advantage. And the last one, the action of making the best or most effective use of a situation or a resource. All the answers were correct. That's why I had to E as all the above. So I'll take my discussion will emphasize much more on the action of making the best of most effective use of a situation or a resource. Okay. So in this case, what are the actions that we take to make the best or most effective use of a situation or resource? In this case, we are saying the resource is the ART. So what action do we take? So before we even take any action, we know that the drugs have to work on a patient. So here, case finding becomes very important, okay? Because you cannot optimize drugs if there are no patients. The only way is to ensure that there is a patient. And where do you get that patient? You have to look for the patient. This is the case finding. And then also, if the resource has to be very effective, we must take actions which are going to prevent this infection from being transmitted from the mother to the child, which we call prevention of mother-to-child transmission. Okay. Now, when we find a patient, what is also important is that you have to link this patient to care and treatment. Okay? Once we have linked the patient to care and we have initiated treatment, we should ensure that the patient is retained in care and we continue monitoring. Otherwise, without that, we just start treatment without ensuring that they are retained and they are taking their medication, then there's no optimization. So the only way the resource can be used at its to its advantage or the best use of the resource is to ensure that once we start, we put them on treatment and retain them in care and continue monitoring. Okay. Just to start with PMTCT, what are the actions that we take? We ensure that all pregnant and breastfeeding women are tested for HIV. And those that are found negative usually are tested every 3 months to ensure that in case one of them is infected, we initiate them on treatment. And also for the negative ones, we should be proactive to ensure that for those who are eligible to start PrEP, they're started on PrEP, okay? And then for those who are infected, we should ensure that we initiate them on ART And in this case, the best resource so far, which brings down the viral load quickly when they are pregnant, in pregnant breastfeeding women, is TLD. I think this debate has gone on. The fear that were there have been allayed. Okay? And once the baby is born, the best use of the resource is to give prophylaxis to the babies according to the national guidelines so that we prevent infection. Okay? Another thing that we have observed is that if we've met mothers who have done, initially they were not infected, but later on they get infected by the still breastfeeding. If we find such a mother, let's start a moniarity and make sure that the baby is started on prophylaxis. If they're not infected, we can confirm with point of care machines which are everywhere. But we can also continue them on prophylaxis while awaiting confirmation. But at this point, I must say, if there's any indication based on our presumptive diagnosis criteria, if you think the baby is infected, start the moniarity without waiting while you're waiting for the confirmation. Okay, and then also we need to monitor for side effects, especially for those that we put on prophylaxis. I'm not saying don't monitor those that are infected, but in this case, emphasis is on those that are on prophylaxis, particularly AZT3TC. AZT causes a lot of anemia. I've been to facilities where babies is on AZT3TC in developing, but they have severe anemia. They are even in cardiac failure. People are diagnosing it as pneumonia, which is possible, but please, can we be more proactive and monitor for anemia? If anemia develops and you think it's going to cause more damage to the baby, then you have to stop the AZT3TC and continue developing. Okay, so question number 2. Newly born HIE exposed infant with birth weight 3.1 kg should receive. So here I want to see what people know or what people remember, what they should give to this baby with 3.1 kg. Moderator.
Thank you, Dr. Mwiya. So the next 4 questions says, newly born HIV exposed infant with birth weight of 3.1 kg should receive, I'll read that, I'll repeat that, newly born HIV exposed infant with birth weight of 3.1 kg should receive. Option A, AZT3TC 1.5 mils BD and nevirapine 1.5 mils OD after diluting 1 tablet of AZT3TC with a strength of 60/30 in 6 mils of water. Option B is AZT3TC 1 tablet BD and nevirapine 1.5 mils OD. C, abacavir ABC3TC 1 tablet BD and nevirapine 1 mil OD. And option D is AZT3TC 1 tablet once a day OD and NVP 2 mils OD. So it's a bit of a wordy question, but these are things that we routinely see in our ART clinics. So I'll invite the network to give it a shot to attempt this question. The key word there is the birth weight, and of course, look at where we are coming from in terms of the guidelines. So I can see that out of 86 connections, only about 20 have polled so far. Now we are at around 20. So I invite the network to give it a shot. Let's hear what your thoughts are. And it will help us understand what we need to focus on as we talk about pediatric drug optimization. So I'll give a few more seconds, 30 seconds to go. And now at 60% of the participants who have voted. So far I can review that no one has picked option C. I don't know why, but we will see from the pattern once I display the results which option got the most votes. Okay, so I'll end the poll in the interest of time and display the results for you to see. So 71% thought A was the correct answer, which is AZT3TC 1.5 mils BD and nevirapine 1.5 mils OD. After diluting 1 tablet of AZT3TC 60/30 strength tablet in 6 mils of water. That is 71% thought that was the answer. Dr. Mwiya, I'll hand over to you so that you take it away.
Okay, yes, thank you very much, Doc. So, indeed, the correct answer is A, because what we give is AZT3TC 1.5 mils BD, and then nevirapine 1.5 mils OD after diluting 6 mils of water. This is the correct answer that we should give. So here I've just put the dosing chart to show what actually happens in the clinic. So the first part where it says there's weight band, then there's nevirapine 10 milligrams per mil. Nevirapine comes as a syrup already. Then AZT3TC, this is one dispersible tablet, which is 60/30, which we dissolve in 6 mils of water, okay, to make 10 milligrams of AZT and 5 milligrams of 3TC per mil. Okay, so on the first part, it says that birth weight less than 2 kg. For the birth weight less than 2 kg, you give this nevirapine is 0.8 mils, and the AZT3TC, the 6 mils you had made, you get 0.8 mils. Equally for 2 to 2.4499, 1 mil, and then for birth weight greater than 2.5 kg, you give 1.5 mils nevirapine and 1.5 mils AZT3TC. So here the catch is it's birth weight more than 2.5. So it can be anything above 2.5. As long as it's birth weight, they get the same 1.5 mils OD and then 1.5 mils of AZT3TC BD. Okay. Then from 6 weeks, the nevirapine is 2 mils. But then for the AZT3TC, it says use treatment dose based on infant's weight. So the one you see down there, which has got weight band, strength of AZT3TC, is what we use as the treatment dose for those who are above 6 weeks. I know that on the actual dosing chart, it says in between the two, the one above and this one, which is weight band, where there's only AZT3TC, it says simplified dose of AZT3TC. It's not supposed to be that. It's supposed to say treatment dose for AZT3TC prophylaxis, so that it shows that we are starting to use this one below from 6 weeks of age onwards. So this is how this one, which is below where there's the 3 to 5.9, with the AZT3TC strength, which is 60/30, then the 1 tablet that side. So sometimes there's confusion because of the way it was weighted in between, where it says simplified dosing of AZT3TC. People took it like anybody who is 3 to 5.9 at birth, they should give 1 tablet. No, that's wrong. At birth, you're supposed to give 1.5 mils, regardless of the weight above 2.5 kg. Even if you compare this with the WHO, this is what it says. At birth is the same dose. Probably it's the handling of the drug for babies. That's why the dose is an upper limit to which you can go. But once you are 6 weeks and above, then you start using treatment dose for AZT3TC, and we've given you down below there the weights that you may encounter for this baby who are 6 weeks and above, and how much you should give of AZT when we say use treatment dose. I hope this is very clear. Sorry, my okay. Yeah, so this is where we were. So just to continue from where I ended, so some of the challenges we have observed when you go to some facilities that when it comes to PMTCT, at times you find that ART, the in charge of the ART section is not aware of what's happening in MCH and labor ward. Okay, so what I mean is that the knowledge, usually the people that are maybe the one in charge, the doctor who is in charge of the ART, has no idea of what's happening in MCH or labor ward. I'll say what I'll justify why I'm saying that. So I find that DBS collection sometimes is done by inexperienced lay counselors. All the nurses are just, they have no interest whatsoever sometimes as to what's going on. We were in a facility where one of the lay counselors was asking the mother, ati nipase nichimbombo chiti chamene using kutenga blood ya mwana wana. So you see, asking the mother which toy she's comfortable with for this lay counselor to get the sample for the DBS, which is completely wrong because they're supposed to collect a sample from a particular toy. So such kind of experiences are what we see, which are unacceptable. And at times I was shocked that in a central hospital, they are using outdated guidelines. For example, mixing 10 tablets of AZT3TC in 60 ml of water, something which we did away maybe 4 or 5 years ago, and it was in a central hospital. And once this mixture is made, in other places, they even kept it for 3 months before use. It's kept in a fridge, so each baby who is born, they give. Now you can imagine water is not a proper solvent for keeping drugs for that long, okay? The worst case scenario was, it was mixed in a yeast drink and kept in a fridge for people to use, which is completely unacceptable. And this is at a central hospital. So one wonders when you go down to smaller facilities, which of course I found amazing because some of them are even doing better than some central hospitals. So this is one of the sad developments. And then the other thing we noted also, there are no dosing charts. If people are giving drugs, they have no dosing chart. So you wonder if there are dosing charts, they are very old and outdated. Okay. Another scenario we found because of no dosing chart, all the babies, remember I gave you this weight bands. So we found that the babies are given, for example, AZT, 1 tablet for each one of them, despite the weight differences. So again, that was very unfortunate and unacceptable in the sense that we are supposed to be following or new guidelines as soon as they are released, at least within a year. Okay, so this is why I said you find that the staff in ART, when you ask the in charge, they'll give you the actual thing that's supposed to be done. But when you go down to labor ward or the MCH, what is being done is different. When you bring it up, they tell you, oh, I didn't know what was happening. So this disconnect should be avoided. That's not the way you can optimize. Optimization can't just work like that. Okay. The next one is case finding. Okay. So now, if we have to optimize, we must sure that we have the patient. We are going to give these drugs, which we want to work effectively. So far, because of finding children who are infected has become extremely very difficult. The screening tool has been suspended in most facilities, although still undergoing validation, and in other facilities, it's still recommended that it's still being because of this validation. Okay. Now, because it has become extremely difficult to find patients, these children, we need to be more innovative in how we are going to find those that who don't come to the hospital. And one strategy is know your child status. Okay. So on know your child status, moderator, I brought in a poll question, number 3.
Thank you, Dr. Mwiya. So poll question number 3 on know your child status says, in know your child status strategy, choose one correct answer. In know your child status strategy, choose one correct answer. A, yield is of great importance. B, coverage is irrelevant. C, it is a useless strategy. And D, coverage is what is required. So those are the options for this question. So let's see how the network will respond to this one. So far, out of 118 connections, we have under 30 people that have participated. Give it a few seconds, maybe 60 seconds, You'll get the feedback from the network on what you think is the correct answer. I must say the options here are quite interesting, Dr. Mwiya. I'll read the question once more. You know your child status strategy. Choose one correct answer. A, yield is of great importance. B, coverage is irrelevant. C, it is a useless strategy. And D, coverage is what is required. So we have about 57% of the network has participated. So I just need a few more so that we get to 70%, and then I will end the poll. Very interesting poll question and extremely interesting options. And I'm sure you will note the feedback that we have gotten, that it was quite an interesting poll. All right, so I will end the poll and display the results so that we can see how the network has voted. So there you have it. 58% of the connections thought D was the correct answer, that coverage is what is required. And we still had about 39% of those that participated thinking the yield is of great importance. No one thought it is a useless strategy, thank God. And we had about 4% that thought coverage is irrelevant. So Dr. Mwiya, I'll hand it over to you.
Okay, thank you, moderator. So in male child status, this is a strategy where we want all children of women who are living with HIV, 0 to 19, tested for HIV, okay? So this is a very, very serious strategy because, like I've said earlier, it's very difficult to find these children. So all those that were sick that are supposed to come, they have been found. So now we have got the most difficult one. So we need one of these strategies. 0 to 19 years, all those children whose mothers are living there should be tested. So in this case, we need to use a separate register to document this activity. Why I emphasize on the register is that if you combine with the sexual partners, it creates a lot of problems. Okay, I'll explain later. So yield is not important. Okay, what is critical is coverage. What we want is coverage, because we know if you're going to look for yield, you'll be very disappointed because a lot of them are negative anyway. So what we need to know is, are they among those that are, oh, a lot of them are negative? Do we find some who are infected? Okay, so the use of a separate register again is to avoid the issue of yield. This is what has created problems, people being scared that the number of children who are positive, who are negative are a lot. So the denominator will be big. As a result, it's going to dilute the yield. This is what has led to a lot of places avoiding to conduct this activity. So please, can we enter them in a separate register so that we're able to account for them separately? Otherwise, if you put them in the register where there are 6 partners, then your yield will go down and then you start worrying. So here, importantly, is coverage. I know that Dr. Meg Aito from CDC, during the early part of this year, we did present an echo when you were presenting on the SAGE strategy. Okay. So having said that, other places have done extremely very well in terms of male child status. People like in Southern Province, they are close to reaching 100% coverage. So if we ask them today, because we usually say, you haven't found the children, because there are those whose mothers fell off from the PMTCT, but they're on treatment somehow, or we've managed to find them, and their children are not tested. Now, with this strategy, we're able to say no, but all the mothers who are HIV infected have been tested. So Southern Province is almost 100% coverage, meaning they want all their mothers who are living with HIV, their children, almost all of them have been tested for HIV. So I was asking my colleagues what kind of strategy they used to reach this percentage. So they went into a campaign mode, even when there were no elections, to make sure that coverage or everybody knows their status. After all, it's one of our first 95. Okay, so what are the challenges that we have observed when you go in some facilities? some of them, this activity is not being done. And there's a lot of people, we work like in silos. There are a lot of counselors. Okay, I'll mention, like for example, not necessarily that it's about DAP, but just to say that, for example, because I know DAP as counselor, just an example, there are staff in the facility, their role is to go into the community. Now the staff in the clinic are supposed to make sure that they do the, child status. So in terms of leveraging on the people that are going to the community to help, they'll say there's a shortage of staff. So that activity is not being done or completely ignored. These are just there to follow those that have lost to follow up. Meanwhile, we have this group which can help us to ensure that this strategy is also fulfilled. Okay. Then the other one is fear of low yield, which I mentioned, because you find they are put up in the same register with sexual partners. There's so much confusion. When you want to look and analyze, if you say, some of them, okay, put ages, then you know they are children. But if there are no children, you find somebody, mother, there are so many people named under her. So start wondering, are all these sexual partners or what? So sometimes it's even difficult to delineate who's a sexual partner, who's a child. And then at the end of the day, anyway, it's also the issue of affecting the youth, which they fear the most issue when it comes to testing the sexual partners. So that's why we're emphasizing on a separate register for the children. So no child status, it's all about children 0 to 19 of all the mothers who are living with HIV or they're on your program, to have them tested for HIV so that we make sure that all those that are infected are found, or we know that none of them is infected. So we're coming to care and treatment in case you found a patient. So this one is linked to linkage and treatment. Yes, moderator, poll question number 4.
All right, so poll question number 4 says, in pediatric ART, the following is correct. A, weight-based dosing is not necessary. B, ABC, 3TC, DTG is a correct regimen for the weight band 3 to 24.9 kgs. And C says, child weighing greater than 25 kg should be given TLD. And D says, nevirapine should be part of the regimen in a child 3 years of age. I'll read those options again. In pediatric ART, the following is correct. A, weight-based dosing is not necessary. B, ABC, 3TC, DTG is a correct regimen for weight band 3 to 24.9 kgs. C, a child weighing greater than 25 kg should be given TLD. And D, NVP, nevirapine, should be part of the regimen in a child 3 years of age. So I'll invite people to take part in the poll. Interestingly, the few seconds I spent reading the questions, no one has attempted the poll, which is quite interesting. And up to now, no one has given it a shot. Dr. Mwiya, this should speak volumes, or perhaps the network is still thinking.
Yeah, the network is still processing, moderator.
All right. So while people are thinking, allow me to read it. Perhaps if I read it a third time, it will be clearer. In pediatric ART, the following is correct. A, weight-based dosing is not necessary. B, abacavir okay, someone says the poll is not showing on the screen. Allow me to just quickly relaunch. Okay. Allow me to just quickly relaunch the poll. People were not able to see the poll. You can launch from your end. Yeah, I'll have IT relaunch the poll, hoping you'll be able to see it, because interestingly, no one was responding.
I started wondering whether I was still practicing.
So we were expecting a few guesses here and there, but then nothing. Okay, are we able to see it now? Yes, we can see some
Yes,
feedback.
yes.
There we go. All right, so let me give it a few seconds, maybe 30 to 45 seconds, so that we get as many people to respond as possible. So I'll read the question. In pediatric ART, the following is correct. A, weight-based dosing is not necessary. B, ABC3TC-DTG is the correct regimen for weight band 3 to 24.9 kgs. C, a child weighing greater than 25 kgs should be given TLD. And D, NVP should be part of the regimen in a child 3 years of age. Okay, so we have a very weighted voting pattern where 71% of the network thinks it's one of the options, and we have the rest hovering between option C, D, A, and B. All right, I almost gave away what was having the majority of the polls. Okay, so in the interest of time, I will end the poll and share the results. So we can clearly see that, all right, I see you're not seeing the results yet. Okay, there we go. So 69% of the network that voted thought that D was the correct answer. And we still had 26% that thought C was the correct answer. And the remainder was split between option A and option D. I'll hand over to Dr. Mwiya to take it away.
Okay, thank you very much, moderator. Let my slides move a bit slow. Oh. Okay. So, okay, I'll emphasize on those questions just to show what is supposed to be. Anyway, we appreciate the answers, and what you see there is a reflection of what actually happens on the ground. Anyway, so here's a patient that you have found. We are trying to ensure that our resource is optimized. So we link the patient to care and treatment. So when we link them to care and treatment, first of all, we do the baseline investigations. Some of them that we do or should do kidney function, liver function, CD4, and also baseline viral load. This is something that's going to be emphasized in the next coming guidelines. Baseline viral load has been coming and going, but I think now to finally agree that we should include this baseline viral load, just making sure that you know that it's baseline viral load, because you'll see that if it's not well managed, you're going to have a lot of your patients appearing as if they are suppressed. So unsuppressed will go high if you don't manage this well. So ART should be initiated with appropriate regimen depending on weight. So in pediatric, weight is of extreme importance. We don't just give drugs without weighing a patient. Otherwise, you're either underdose or you poison the patient. So the current recommended regimens that we use are Zidovudin, Lamivudine, Nevirapine for 0 to 4 weeks. Remember that we are coming from an era where we were giving AZT3TC, which is Zidovudin, Lamivudine, Nevirapine for 2 weeks. Then from 2 weeks, we picked it up with ABC3TC, Lopinava. But now that we have a DTG 10 milligrams, our guidelines are changing. For those facilities that have already received the 10 milligram DTG, our first line now will be ABC3TC DTG, and our second line AZT3TC Lopinava, Ritonava. Then also we have Tafet, which we start giving when a patient hits 25 kg, and then TLD when you reach 30 kgs. So that 25 kgs which we put there for TLD is actually what we have seen. Patients whose weight is low as 10 kgs, somebody will prescribe TLD. Please, TLD, tenofovir lamivudine, the rotographer, should only be given or prescribed to a patient weighing 30 kgs and above, while tafate is 25 milligrams above and above. In addition to that, don't forget to screen for TB and initiate TPT. Okay, so these are our regimens, that we are going to be using moving forward. If there are any changes, obviously you'll be communicated to. So as we move forward, 0 to 4 weeks, which I had mentioned, that one was 0 to 2 weeks where we're putting up to nevirapine, but now we are putting AZT-3TC-NVP for the first 1 month, okay? And that's the preferred regimen. Here, I must say that the reasoning was, if we said we give AZT-3TC-nevirapine for the first 2 weeks, then ABC-3TC lopinava the next 2 weeks before 1 month, then you go to DTG at 1 month, they're going to be out of confusion. So the best is AZT-3TC for 1 month, then you go to DTG. DTG 10 milligrams is only applicable for a baby who is 1 month old and weighing 3 kg. That's where the DTG 10 milligrams start from, okay? Just to go back on the first one. So the alternative there, if you don't have the AZT-3TC, you have issues, you have to consult 7040 so that we plan what's the next we can do for this child who's infected, okay? So about 4 weeks, 3 to 24.9 kgs, there we have put ABC-3TC DTG as our preferred first line. Our alternative is ABC-3TC lopinava. In above 25 milligrams, this is where tafate comes in, tenofovir, tristabine, and rotograva. And then the alternative is ABC-3TC DTG. In above 30 and equals 30 kgs, here in PEDS, we still prefer tafate, although COD, which is tenofovir, hydroxyfumarate, lamivudine, and the rotograva. Okay. Why you see the 3 to 4.9 kgs is that 3 to 20 kgs use the 10 milligram DTG, less than 19.9 kg milligram DTG. Then at 20 kgs, obviously this one you are aware, we use the 50 milligram tablet. Okay, what about somebody who is co-infected? So here we 3 to 9.9 kg, we have said ABC-3TC DTG, because when you have TB, we don't use tafate. So rather there's ABC-3TC DTG. And once you're on TB, here DTG is given twice a day, okay? But if this cannot be tolerated, then you can give ABC-3TC DTG, ABC-3TC AZ, which is a triple nuke. This is one of the worst case scenarios where you have nothing, or you have issues with the DTG, but otherwise the best is the DTG. If you can't, then you have the ABC-3TC lopinava. So here you have to super boost the lopinava or double dose. These are the solid formulations. Granules you don't use with rifampicin, but above 30 kgs, there's a TDF, 3TC, so TOD. You can give TOD above 30 kgs, but the TG has to be given twice a day, and the alternative is ABC-3TC DTG, or you can do TDF 3TC lopinava, which is super boost. Okay, so this is now showing us the second line regimen if you failed the first one. Obviously, the first 4 weeks failure is unlikely, but in the event there's something, you can call 7040 we discussed. But for the 3 to 24.9 kgs, if the first line was ABC-3TC DTG, the second line will be AZT-3TC lopinava ritonava. Alternative one is the darunava there, which is featuring. Okay, it's like if you are on ABC-3TC lopinava, the second line will be AZT-3TC DTG. Okay, so once you are on DTG first line, second line will be lopinava. If it was AZT, it was ABC, second line will be AZT. Same as tafate and the TDF still use the AZT. So this is just a dosing cap for the first line regimen. It gives you the weight band, the strength of a tablet, the number of tablets which you prescribe to the patient, or what you tell the patient how to take. Then the last one is how you enter on smart care. What is important here to note is that the ABC-3TC is given once a day. where we are coming from, we are giving the ABC 3TC twice a day. But because the DTD is given once a day, we want our children also to benefit from the once a day. The half-life of ABC is quite long to allow us, and the 3TC to allow us to give it once a day. Please take note. Here we have a strength of a tablet, then in the middle number of tablets, and here it shows you what you enter in smart care. Because we've seen also challenges where in smart care, people just put the strength of a tablet instead of actual dose. So you don't know whether the patient was given the correct dose or not. In places where there are smart pharmacists, they will correct. And then they will say, look, the doctors just put the strength, not necessarily, or clinicians, so they don't tell us exactly how much to give. Okay, so this is how this was designed. I also want you to the 4.9. Here we have given two formulations of ABC3TC. In case you have the 300 milligrams, it shows you how much you should give of the ABC3TC. And if you have the 120-60 milligrams, same weight band, it shows you how much you should give. But just also take note that if you have a 300 milligram tablet of ABC and you have the dispersible tablet of 120-60, the ultimate dose there for the ABC3TC, if it's a 120-60, what finally you give correct. Don't say how.
Okay, I just want to confirm if we can all hear Dr. Mwiya. Anyone? Okay, so we seem to have lost Dr. Mwiya, and we are in the dying minutes of the presentation. And we should be preparing to get to the case presentation. I see he has just maybe 5 more slides to wrap up.
Yeah, sure. So this was this
maybe
one.
At this point, allow me to just invite for any questions. Okay, Dr. Mwiya is back.
I'm back.
Okay. So he's
Let me just
dropped off once more. So allow me to just invite the network to ask any questions, discussion. We have a panel of experts on the call who will be able to help us answer some of the questions. And then when Dr. Mwiya comes back, we should be able to wrap up the last 3 or 4 slides he had and move into the case presentation. So I do realize that we've actually depleted most of the time that's allocated to this session.
Sorry, I'm back.
All right, thank you, Dr. Mwiya. Maybe in the next 3 minutes, if you could help us wrap up so that we have the case presentation. Yeah.
Okay, so just to, so some of the challenges in care and treatment, absence of dosing charts, patients being dosed wrongly, and also prescriptions not being correctly. And sometimes we find CBVs are the ones who are dispensing drugs, even when they are qualified staff, something which is not to be accepted. Okay, and patients being dosed on an assumed weight, sometimes on a previous one, done months ago. Okay, and then another challenge is disclosure of HIV status to the adolescents not being done. So they can't appreciate where they are taking, so optimization cannot work effectively. In terms of retention and monitoring, so here we have to make sure that we monitor our patients following our guidelines. I mean, we know all of us in terms of VL, it's 6 months, 12 months. If they are suppressed, it's yearly. If they are suppressed, we put on EAC. So at every visit, we have to weigh the patient, drugs based on, dispensed based on weight. Okay, and also we encourage that they should come with empty bottles previously dispensed. This helps to know whether the patient is still on the correct drugs, is the correct dose, and the drugs are not expired. And then also to encourage retention, we should do MMD, multi-month prescription. 3 MMD, I think a memo came out, 2 to 10 years, we need for 3 MMD, and then above 10, 6 MMD. But just to note, those between above 5 to 10, if they are stable, there's a stable caregiver, they are suppressed, you can see adherence extremely well, you can give them 6 MMD. And also make sure that you address all the issues that affect adherence. Locator must be updated all the time. We should work closely with the OVC partners so they help us in case patient is not issues with adherence with their homes. The OVC partners can help us. Okay, and this one I've mentioned. So the challenges we have seen in most places, no viral done, or if it's done, it's done beyond the recommended time. Other investigations not being done correctly. Then we also have seen where blood is collected by CBVs. EAC sessions being done by CBVs when nurses are there. Okay, at times patients are kept on failing regimens for a long time. People fear to change, okay, and to switch clients. And then at times, the multi-month description is not given even if the patient is eligible, but meanwhile there are enough stocks. So I think we need to be more proactive as clinicians. And also let's work with our OVC partner. This will help us to optimize. Okay, thank you very much. This is where my presentation ends. Over to you, moderator.
Thank you so much, Dr. Mwiya, for taking us through this very interesting didactic presentation on pediatric ART optimization. So at this juncture, we are just 45 minutes shy of the hour mark. I will ask that if there are any questions, quick questions or clarifications based on the presentation that has been made, that you submit them through the chat box, or you can signal to me by raising your hand and I'll give you a platform. While that is happening, allow me to ask the team from Kabwe to prepare their case. If you can actually go ahead and share the screen for your presentation. Are there any questions, contributions, clarifications?
There's one question in the chat, moderator.
All right, thank you so much. So there's a question from Brighton Kakumia, who asks, when is the pediatric DTG going to be available in all facilities? Hey, Dr. Mwiya, I can throw that to you.
Yeah, okay. Dr. Chungu, let me also throw to Dr. Chungu. He's the chair of the transition committee. Dr. Chungu.
Yes, Dr. Mwiya.
Yes.
No, sorry. I'm asking if you can repeat the question.
All right, Dr. Chungu, the question was, when is the pediatric DTG going to be available in all facilities? Dr. Chungu, did you pick that one up? Dr. Chungu, or well, any of our experts who can answer that question? Okay. I'd like to confirm that you can hear me.
Yes, we can hear you.
We seem to be having lapses in connectivity. So once Dr. Chungu, Dr. Mwiya are available to respond to that question, we will definitely repeat it. So there's another question which has come. How do you deal with a child whose weight fluctuates between 24 and 26? I assume this is ages. Should you modify the regimen back to ABC3TC-DTG from TAFED if the weight drops below 25 kgs? So my assumption is you're asking the child initially had attained the weight band above 25 kgs, and as they are on the treatment, their weight drops for one reason or the other. So do we switch back? I'll throw that one to Dr. Thomas. Are you able to pick it up?
Sorry, I was in another call. Let me just hear the question.
The question was, how do you deal with a child whose weight fluctuates between 24 and 26? Should you modify the regimen back to FBC, 3TC, DPG from TAFED?
No.
So assuming a child did get
Yeah.
to 25 and then they lose weight after being transitioned to TAFED.
Okay, for that case, we will still maintain TAFED in the assumption that they will catch up the growth. Thank you.
Thank you so much.
And the other question I was asking Dr. Mundari, she said by February next year, PDTG will be rolled out to the whole country. Thank you.
Thank you so
Okay.
much, Dr. Thomas. Yeah, I see Dr. Mwiya is back and Dr. Chungu.
Yes, Dr. Moderator, I think I agree with Dr. Thomas. We maintain because we hope that they will regain their weight once we have handled what is causing them to lose weight. And then the next one I think has been handled well by February next year. Actually, I was waiting to hear from Dr. Montari. So thank you, Dr. Thomas, for that. Over to you, moderator.
Sorry, Dr. Mwiya.
Yes, Dr. Chung.
Yes, I just wanted to take the opportunity to also emphasize that one of the challenges we've had is that the initial sites where PDTG is being rolled out, if sites can stick to the guidance that has been given, because we understand that there's a lot of demand for the product, but if we keep adding sites that are not in the original plan, it's going to destabilize the supply chain. So this is just an appeal to the initial sites that were marked for the first phase of the DTG rollout to just adhere, and for the other sites, we know that yes, it's something that we are all very keen to follow, but we need to really heed to the guidance to use the commodity in the sites that were targeted. Over.
All right, thank you so much, Dr. Chungu. And while you are at it, there's a question in the chat saying, why don't we give TAFED in HIV/TB co-infected individuals with a weight greater than 25 kgs, but less than 30 kgs? Does it have to do with the drug toxicity? Maybe you could quickly respond to that one, Dr. Chungu.
Yes, so thanks, Dr. Singeni. There is just an issue of no safety and tolerability data yet. So it's an issue of where there are studies yet to be done. I'm sure Dr. Mwiya is writing a protocol on that one.
All right, thank you so much. I hope Lyndon Mfungwe, that was a helpful response. I'm cognizant of time. At this point, allow me to invite our colleagues from Kabwe to take us through the presentation, and then we'll build up on the discussion after the case presentation. So Mrs. Siame from Kabwe, you can take it away.
Thank you very much. Good afternoon, everyone.
Good afternoon.
Good afternoon.
Yes, my name is Mrs. Siame Judith Nalabwe from Kawe Women, Children's and Newborn Hospital.
Sorry, Mrs. Silava, to interrupt. Just request that you put it in PowerPoint mode.
Okay. Just a minute.
In slideshow mode.
Okay.
Are we succeeding? Well, if you would allow, we could also do it from this end to
Okay, sure.
share the screen. Okay.
Okay.
So our IT will display the case for you, and then you present as we transition the slides from our end.
Okay, sure.
Thank you. But I note in the chat that Dr. Mwiya mentioned that she could not hear us. I hope the audio has been corrected now, Doc. Okay, Kawe, you can take it away.
Yes, thank you very much. Good afternoon once again. Yeah, our case presentation for today. Let me take you into a brief history of our case presentation for today. NM, female, 4 years, RVDR, on ART for 2 years. This was a referral from Likumbi Rural Health Center under Kapirimposhi District Hospital. The child came as a case of anemia to rule out gastritis and was admitted on 6th January 2021 at Kawe Women, Newborns and Children's Hospital. 3 months history of ill health, presented with fever, abdominal distension, vomiting, poor appetite, night sweats, weight loss, but denies cough. There's also a history of visiting the health facility 3 times for the similar complaints and was being treated with oral antibiotics, that is CTX and amoxicillin, and only referred on the 4th visit. Past medical history is the non-RVD patient on ART since 2019. There's no history of TB, no history of sickle cell, no history of epilepsy, no history of asthma, and no record of VL was recorded. Followed up with KCH, which is Kawe Central Hospital Lab, the PCR lab for viral load results. Lab acknowledged receipt of sample, but yet to be processed. Drug history, the patient has been on abacavir, lamivudine, and lopinavir. CTX, folic acid, and ferrous sulfate. Birth history, the child was born as SVD and weighed 3.5 kgs at Chisunka Rural Health Center. Mother was RVDR, but not on ART. She was still on pre-heart. Baby was not started on prophylaxis due to parents being in denial. Family history, mother is non-RVDR. Social history, parents are present farmers. Child is the firstborn of 2. And our physical examination, which was done on 6th January 2021, the child was ill, pale, and weighed 10 kgs. Cervical lymphadenopathy and submandibular lymphadenopathy were present. Chest clinically was clear. S1, S2 was regular. The abdomen was distended, soft, and marked with the hepatomegaly. Our investigation that we did, which you are going to see in the next slide, were the baselines, and then chest X-ray, which revealed the opacities on the right lung. And then 2 for gene expert was collected, and the results were positive for MTB. Our diagnosis was made as extrapulmonary TB in HIV stage 4. Patient was commenced on 4F disease, which is the Thambutol, and the 3F disease pediatric doses. Vitamin B6 was prescribed, and patient was to continue on ABC 3TC, lopinavir, but to double the dose of lopinavir, and also CTX was prescribed. Patient improved and discharged from the hospital on 13th January 2021. And follow-up sputum at 2 months. That was after the discharge of the patient at 2 months, and then at 5 months and 6 months, and sputum came out negative for MTB. Patient was cured on 19th July after 6 months being on ATTs, 19th July 2021, and the weight improved to 13.5 kgs on discharge. Our baselines samples that we collected on 6th January, HB was 6.6, and regimen was still ABC, 3TC, and lopinova. And then on the 7th January, we did LFTs and RFTs, and for ALT was 9.3, creatinine was 27.5. On 8th of January, we collected CD4 count as a baseline, which was 843 cells. Next slide. And our questions for today. Number 1, what are the challenges in the screening and detecting TB in HIV-infected pediatrics patients in rural facilities that are contributing to late diagnosis? Number 2, how can we improve on the turnaround of viral load results for our pediatric patients in rural areas in COVID era, where the same machines are used for COVID samples? Number 3, how could we have managed this patient differently in terms of ART? Thank you.
Thank you so much, Kabwe. Thank you so much, Kabwe, for that interesting case, and also for sharing it with us. I'll just quickly summarize that it's a case of a 4-year-old female who's HIV positive and is on medicine for the last 2 years of her life, presented to the facility with a 3-month history of ill health with various symptoms, including but not limited to fever, abdominal distension, loss of appetite, night sweats, and weight loss. This is a patient that also on clinical examination had hepatomegaly and had lymphadenopathy. The chest examination as well as cardiac examination was unremarkable, and investigations that were done confirmed that this child had tuberculosis, and this was based on S2 expert. So the patient was commenced on ethambutol, the 3-FGCs, and vitamin B6, and was continued on cotrimoxazole, and the patient had improved clinically and was discharged from hospital. So the questions from the team on the ground in Kabwe was what was they want to understand challenges that are being faced in screening and detecting TB in HIV-infected pediatrics, and how can we improve on the turnaround time of viral load results for pediatric patients, considering the demand for the machines in the era of COVID. And they are also asking how best could this patient, how best could they have managed this patient to improve the outcomes. So I did see there was a hand from Dr. Ngoma. Dr. Ngoma, please unmute yourself and ask your question or seek your clarity. Tubiwe Ngoma. Okay, while we are waiting for Ngoma to unmute herself, is there anyone else who has a question or clarification or something you would like to learn from the way this case was managed? So I see in the chat, there's a question from Mazabuka General asking why was the mother pre-ART and what was the antenatal record? Maybe Kabwe, you would respond to that. Dr. Thomas, I've seen your hand.
Yes, I also want to clarify something. The height and what was the SD score and the lopinavir, what formulation did they use? Was it a tablet or a granule? And then why we didn't do the lab test? They saw the child in January and again in July. We don't have any viral load results. So I just want to verify a few things. And also the sibling was tested. Yeah, just a few clarifications. Thank you.
Thank you so much, Dr. Thomas. So Kabwe, Dr. Thomas seeks to understand if you did any anthropometric measures on this child, what was the standard deviation score for this child? And also the lopinavir that was given, was it granules or it was the syrup suspension? And then we've noted that there were no results for viral load that were reported. Any issues related to that? And finally, the sibling to this child, were they tested for HIV? Kawe? Mrs. Siam, are you able to speak to those points of clarity?
Yes, let me start.
Please go ahead, Mrs.
Okay, I'll start with the sibling. Yes, the sibling was tested and the results came out negative. And then I'll go to why was the mother still on pre-ART. The mother was still on pre-ART because they were still in denial in order for them to start ART. Especially the pressure was coming from the husband, not to start ART. And
Okay.
yes, and on the lopinavir, whether it was granules or tablet, by then in January, we were using the tablets and the suspension, the way we are treating. The granules were not in stock by then.
All right. And then there was a question about doing the Z score for the child. Was it done for this child? Do we know if this child was malnourished or not?
Yeah, yes, the Z score was done. The MOH was 12 centimeters. And then the Z score was below -3.
All right, thank you so much. Another question. So you have attempted, you have responded to the question on the pre-ART. There was pressure from the husband. That's why the mother didn't start. Now there's also a question probably which will go to the experts on when you diagnose TB in pediatric patients using STU expert. What should you use? Do you use sputum for follow-ups? I think that's a question that I'll throw to Dr. Chungu thereafter. Any other points of clarification? I see there's a hand from Dr. Chungu and St. Francis. Let me start with St. Francis, then I'll have Dr. Chungu come in.
Hi, good afternoon. Sylvester from St. Francis Hospital. Just want to find out what sort of counseling models were used when handling this client, the mother in particular, because we are hearing that the reason why the mother didn't want to start ART treatment is because there was pressure from the husband and things like that, which shows that there probably wasn't much that was done to tackle that, because why would one deny themselves the right to medication simply because of a marriage? So most of the times we want to deal with the root causes. So what sort of counseling models were used to tackle the root cause? And why is the same patient still not, accessing ART treatment if they're still not accessing it?
Thank you so much, St. Francis. I think the question was quite clear. I'll ask Dr. Chungu also probably to give a comment or a clarification, and maybe he can also attempt one of the questions in the chat. Dr. Chungu.
Okay, thank you, Chair. Can you hear me?
Yes, we can.
Okay, so there was a question on the need for the repeat specimen, and so the question is that it is a good question because we don't recommend repeat specimen collection due to like the challenges with collecting specimen in children, unless maybe you want to repeat your gene expert because you want to reevaluate the child. Let's say it's a child who's not improving, and then you want to see maybe could we have been dealing with a resistant strain or not, but clinical improvement on its own is grounds enough for you to do a final diagnosis as happened in this child. Even repeat chest x-rays are not routine because you will still get sometimes residual radiological involvement from your baseline x-rays. I agree with Dr. Thomas on the need to always have a Z score in these children because of, co-managing malnutrition. And already we can see that this child had severe malnutrition, which means needed, like special management as well. Then just always emphasize that anemia is always secondary to something. So like that's in the initial diagnosis that was of this child, it should have been anemia secondary to this. And also the gastritis, it seems, was linked to the abdominal distension, also not very clear. The other thing, this child is 4 years, but we are using absolute CD4 counts. There's 843 there. We should have been using percent because of the age of the child being less than 5. And then the final one is, it's not very clear why we're saying extrapulmonary TB. Maybe we can get more clarity from the CAWE team, but also this is a very good case because it shows, common challenges and TB being a big comorbidity in HIV infected children. So for me, just clarity on why it's extrapulmonary TB. Thank you, Chair.
Thank you so much, Dr. Chungu, for responding to the questions and also seeking that clarity. Maybe another thing, I may have missed it. There was a question from someone in the chat box saying, since this child was diagnosed using STU expert for TB, how then do we follow up this child? Do we need to use the sputum, or is it related to what you just mentioned about the fact that clinically the child is improving and that's sufficient? Maybe you could just clarify that in case I missed it. Dr. Chungu? All right, so CAWE team, can you just respond to the concern from Dr. Chungu as to why we are saying it's extrapulmonary TB?
Through the chair, Dr. Banda here, part of the CAWE team.
Yes, please go ahead, Doc.
Thank you so much. So the extrapulmonary tuberculosis was due to the lymphadenopathy that was there, the cervical and the submandibular lymphadenopathy, and of course they are characteristic, they were matted, and also the chronic abdominal pain and the distension that the patient came with. So that's why we thought of extrapulmonary tuberculosis. I submit.
Thank you so much, Dr. Banda. Just checked also that in the case you did highlight that even on X-ray, you did notice that there was an abnormality in the X-ray. So maybe with those facts in mind, I'll ask Dr. Thomas maybe to also shed more light on whether or not we can maintain extrapulmonary TB or pulmonary TB in this patient, or is it disseminated TB? Dr. Thomas?
Yeah, I think it's like, because the expect is positive, that means, and the X-ray opacities. So it's a pulmonary TB, and even the reclassification, even if there is other sites involved, if the lung is involved, it is classified as pulmonary TB. That's why what I think. Yeah. And then of course, the cervical lymph node matter is there. I don't know the abdominal distension. Was there any fluid? Or since the child is malnourished, is it just something else? I don't know, but I think it should be pulmonary TB. Thank you.
Thank you so much.
Pulmonary and disseminated if there is distension, ascites, those involvement, yeah. Thank you.
Thank you, Dr. Thomas. I think in the history, they did emphasize that there was a hepatomegaly, but I didn't quite get the history, or rather the examination finding describing distension of the abdomen. So at this point, allow me to go now back to the questions that I were asked as to just help them in the managing of cases like this one in future. They asked to say, what are the challenges in screening and detecting TB in HIV-infected pediatric patients in rural facilities, and that is contributing to late diagnosis? So any takers for that question? Dr. Banda, I see your hand is up. Is that to respond to the first question, or it's an old hand?
It's an odd hand. Sorry, Doc.
Okay. Yeah, so I invite any of the experts to take up that question in line with the experience working in the various facilities, but the challenges that are being faced in screening for and detecting TB. And also you could actually speak to how best the facility could have managed this patient considering their circumstances. So I'll throw this one to Dr. Mwiya, just shed a bit of light. Then we'll go to Dr. Chungu afterwards to speak to the question on the viral load results in the wake of the COVID-19.
Okay, so I think the first one, indeed, it's a challenge in terms of managing, making a diagnosis of TB in the rural areas. It means that they have to depend much more on their clinical acumen to make a diagnosis because of the limited ability to do any laboratory diagnosis. So that one is quite a challenge, yes, I agree. But we should be, as health workers, be much more knowledgeable in terms of clinical acumen. I think that's the best we can do, and refer where appropriate. But if we can, there's a gene expert machine, and we can send the appropriate specimen like they have done here. They did send this to for diagnosis. So for sure it's a challenge, but I think we can still better as long as we have a high index of suspicion and get the appropriate sample for gene expert examination. And where we can't manage, we send to the next level of expertise. And in terms of managing the patient, I think under the circumstance, they tried their best. This is why Dr. Thomas was asking whether we were using syrup or tablets, because what's recommended to double dose is the tablets. But anyways, this is a 4-year-old child. The only difference at this point I would say is, okay, at that time, if they had, I think a Favirenz was still available, we could have given the patient a Favirenz and avoided the use of lopinavir because of the issues of double dose, and sometimes anyway, the efficacy because the levels of the lopinavir is reduced. But at this point where we are, DTG would be appropriate since we have 10 milligram tablets. At least this one has saved us. But in terms of the best that they could have done, I think they did the right thing. We can't take away anything from them under the circumstance in terms of ART. But of course, we don't know other issues when it comes to malnutrition, where the child had, how the patient was managed. But in terms of ART, I think they did the best they could under the circumstance. I submit. Over.
Thank you so much, Dr. Mwiya. I'll ask Dr. Chungu also to just add voice to how best they could have managed this patient, and also speak to very low turnaround time in rural areas in the wake of COVID-19.
Okay, thank you, Chair. I think the month of November has been designated by the NTPLP as Childhood TB Month. And one of the reasons why this was done was just to highlight the need for us to always keep childhood TB at the back of our heads. And in one of the sessions that we had, there was a similar scenario to this, a child that keeps coming, you know, with a cough, weight loss. And so we need to think TB in an HIV endemic country. And I do agree with Dr. Thomas on how WHO now says either PTB or extrapulmonary TB. And then the reason why that is done is because of the fact that when there's pulmonary involvement, there's increased transmission. But we know that children less than 7 years typically don't transmit. But just adding to what Dr. Mwiya said, specimen collection in children, it requires a bit more effort, but now we are privileged that we have STU, which can be put on the GeneXpert platform. So STU is much easier to collect, and the thinking there is that this is the microorganism is swallowed, and that's how it ends itself in STU. So it's also classified as PTB. Though there's also intestinal TB that you can get from STU-Expert. So I do agree with you on the issue of the COVID and the GeneXpert sharing a platform. Unfortunately, it's a challenge we have upon us. Both are priorities right now. And I think maybe Dr. Mwiya would be better placed to guide on how best we can, utilize the two platforms. But just to say, where there's a high index of suspicion for a child, please, let's make all efforts to trot down to the lab and ask for a specimen to be processed. I think it's important that we follow up. Thank you.
Thank you so much, Dr. Chungu. I think we have under a minute to go. I'll ask Dr. Thomas for any final thoughts on how best they could have handled this patient.
Yeah, no, that one is already discussed, but I just want to re-emphasize the fact that Kaletra is already out from the country, so we don't have to worry. Even the granules, double dosing, it won't give enough level in the blood, so it is not advised. Only the solid tablet form is advised to be double dosed with the ATT, rifampicin based. And again, after stopping the ATT, we have to continue the double dosing of lopinavir or BD dosing of DTG for another 2 weeks. I just wanted to re-emphasize those points. Thank you.
Thank you so much, Dr. Thomas. Thank you so much, Dr. Chungu, Dr. Mwiya, and Kabwe Women and Newborn Hospital for bringing up that case. It has really helped us understand the real-time challenges that we face in our respective facilities to sort out dosing in pediatric patients, especially in a case like this one, where we had HIV-TB co-infection. And it does pose a challenge in terms of how you combine the drugs and how you work out the doses for the particular weight band. I do take a note that there was a question that was asked about what counseling model was used to speak to the mother, considering that she hadn't started the ART. Maybe you have a quick response, Kabwe?
Thank you so much. So for the mother, it was just on her first pregnancy when there were those challenges in terms of ART, but after the child was found to be HIV positive, That was 2 years ago. They were initiated. The child was initiated together with the mother, as well as the husband as well. In terms of knowing the counseling model, it is very difficult for us to respond to that because this was happening at a rural health facility, Chishinka Rural Health Facility, and we were trying to get in touch with them. Unfortunately, we couldn't. But the goodness is that they have all been initiated on ART. I submit, Chair.
Thank you so much for that submission. And some word of encouragement from Dr. Thomas is that please follow up the issue of the viral load to help us in the managing of this patient. So looking at time, I think I'll have to wrap up today's session. You may agree with me that today's session has been a very, very, very interesting session. And we hope that this session has helped patch up some gaps with respect to pediatric ART optimization. And also, you know, the case that was presented by Kagwe is one that we could go on to discuss more and more. Being someone coming from a TB program background, I'm tempted to bring up the topic of reverse contact tracing. Say, did we do reverse contact tracing? But it's a story for another day. So I'd just like to thank everyone that has stayed on the call today, the experts that have shared their knowledge, and more so Dr. Mwiya for leading us through the didactic presentation and also being available to answer the questions that have arisen from the network. And also Kagwe, thank you so much for the case that you've brought up. We've really, really, really learned much from it. At this juncture, allow me to just thank everyone and let us optimize the ART treatment because we know that the future of Zambia is in the pediatric population. Thank you so much, and we are signing out.